Thank you, Dr. Langer. Thank you for inviting me. I would like to thank the staff who coordinated this meeting. I know everybody was a little nervous because I arrived this morning, and coming from Detroit in the month of November is always a challenge. Fortunately, I missed a snowstorm, but folks in Chicago and Detroit are experiencing something like 5 inches of snow right now. Anyway, these are my disclosures. This is what I'm hoping to do, sort of briefly discuss immune cycle. Though Dr. Haas has made my job easy. In fact, I've realized that there's a little bit of an overlap with some of the other speakers, and I'll do my best to minimize, sort of highlight some of the things that may not have been mentioned. I was going to talk about anti-CTLA-4 as well, because frankly, this was the first immune checkpoint inhibitor that was evaluated in non-small cell lung cancer and some of the combinations, and then briefly touch upon some of the other targets that we are focusing on in terms of activating cytotoxic T cells. So this slide was shown by Dr. Haas, and I think in understanding how these immune checkpoint inhibitors work, it is always worthwhile to review this so-called immune cycle and what we are trying to achieve. So tumor antigens are released from the tumor either because of spontaneous necrosis or under the effect of cytotoxic agents such as radiation or chemotherapy, which are then picked up by the antigen-presenting cells, which traverse to the regional lymph nodes and activate the cytotoxic T cells, or prime the cytotoxic T cells to the tumor antigens. And one of the other factors is it increases the circulation of the T cells. So you can see that at least in some patients after drugs like anti-CTLA-4, there's lymphocytosis that is observed. Eventually, these T cells extravasate into the tumor microenvironment and then sort of attack the tumor based on recognition of the tumor antigens. And then that leads to further release of the tumor antigens, and this sort of immune cycle continues and hopefully leads to an effective immune response against the tumor. What is also important to recognize is that there is a tumor microenvironment that is actually trying to inhibit this activity of cytotoxic T cells. So there are inhibitory cells, such as the T regulatory cells and tumor-associated macrophages, that are limiting the ability of cytotoxic T cells that may have extravasated from the circulation to mount an immune response. And what we are trying to do basically is, in the tumor microenvironment, sort of tilt the balance towards a greater number and activity of these activated cytotoxic T cells and inhibit the activity of these inhibitory cells. Now, when we look at the cytotoxic T cells that can attack the tumor, we have up till now focused on the inhibitory molecules, particularly PD-L1, CTLA-4, and drugs that target PD-1. What is important to recognize are there are these co-stimulatory molecules also present that can activate the T cells. And so you can have inhibitory molecules, rather antibodies that inhibit PD-L1 or PD-1 or CTLA-4 that block these molecules, block the signaling, and thus inhibit the inhibitory effect of these molecules. But you can have agonistic antibodies for the co-stimulatory molecules that enhance the activity of these cytotoxic T cells. And I'll come to this issue a bit later on. So I'll start off with CTLA-4, which I mentioned was the first immune checkpoint inhibitor that was evaluated in non-small cell lung cancer. Sorry. Basically, if you see, as I mentioned, once the tumor antigens are picked up by antigen-presenting cells like the dendritic cells, they go to the regional lymph node and activate the T cell. But at the same time, presence of CTLA-4 can limit this activation, as well as limit the ability of these cytotoxic T cells to get into the circulation. And so what is important to recognize is CTLA-4 probably, anti-CTLA-4 probably is working, as mentioned by Dr. Haas, at the activation phase, whereas in contrast, the anti-PD-1s are more active in what I call the execution phase, wherein the T cells are directly interacting with the tumor. So the trial that was done in non-small cell lung cancer of ipilimumab was a randomized phase 2 study, and I'm sure at the back you may not be able to see it very well. This was published by Dr. Tom Lynch in 2012. And patients with advanced non-small cell lung cancer, all histologies, were randomized to carboplatin or paclitaxel as the standard arm. And there were two sort of experimental arms, with one arm being where ipilimumab was started with the first cycle, and the second arm was what was called as the phased-in regimen, where the ipilimumab was started with the third cycle. The reason why two different arms were evaluated was that there was a concern that the steroids given with chemotherapy may limit the activity of ipilimumab, and so it was felt that there would be minimal interaction with the steroids since it was coming in with the third cycle. The primary endpoint, what was defined as immune response-defined progression-free survival, as was mentioned by Dr. Haas, there is occasionally pseudo-progression with ipilimumab, and so there are these modified criteria called the immune response criteria, and so this was immune response defined, not the standard RECIST-defined progression-free survival. And what this study showed was that there was an improvement in the patients who received phased-in ipilimumab compared to patients who received standard chemotherapy. Similar benefit was not seen in patients who received concurrent ipilimumab and chemotherapy. Now, did really the starting of the ipilimumab with the third cycle make a difference in terms of the steroid interaction? Unclear. When you look at the overall survival, there was a hint that in the overall population, there was a benefit with the phased-in ipilimumab, but there was no benefit in the concurrent ipilimumab arm compared to the chemotherapy-only arm. What was interesting is in a retrospective subset analysis, there did appear to be a survival difference in the squamous cell patients with a hazard ratio of 0.48. And based on these data, a randomized phase 3 study, which I believe has already been completed, was conducted in squamous cell lung cancer patients, and we'll see what those results show. Now, what is clear from any of the data from immune checkpoint inhibitors, and I'll come to this more when we discuss PD-1, is it's clear that these drugs work in a proportion of patients, whereas there's virtually no activity in a certain group of patients. And so there has been a great deal of interest in understanding the biomarkers of efficacy, which are the patients who really benefit. Now, this data is from melanoma, wherein they took just 64 patients, and in their exploratory phase, they looked at 25 patients, 11 who had an excellent response, and 24 who had, 14 who had a very poor response to ipilimumab. And they did a exome analysis and sort of identified gene mutations that coded for tumor neoantigens. And they came up with a signature which showed that patients who were positive for the signature, there was a distinct difference rather in the signature between patients who had a response and who did not have a benefit. And this was validated in another group of about 35 patients. The only reason to show it's not clear whether similar sort of a genetic signature will be valuable in non-small cell lung cancer as well, but it does appear that expression of certain number of tumor antigens does appear to be relevant for seeing efficacy with both anti-CTLA-4 as well as anti-PD-1. So coming to the anti-PD-1 drugs that are in use now, so this is mainly at the level, as I mentioned, at the tumor microenvironment. And I know I'm repeating myself about this, but actually, about 3 years ago, I had absolutely no knowledge of immunology. I don't know if I still know immunology. But it, to me, helps to sort of go over this immune cycle to truly understand how these drugs differ and why one would consider combinations. Or for that matter, there is data to suggest that steroids might have a greater impact on anti-CTLA-4 activity, but may not have as much of an impact at anti-PD-1 because steroids impact more of the circulating T cells, which is what CTLA-4 increases. So having a sense of where exactly these drugs work is helpful. So I'm sure Dr. Pike in yesterday's presentation went over these data where based on initial very promising phase 1 results and the initial impression that this drug may work better in squamous cell patients, a randomized phase 3 study was launched. that randomized patients who had received one prior platinum-based chemotherapy to nivolumab versus docetaxel, the standard of care. The primary endpoint was overall survival, and it did meet the primary endpoint with a hazard ratio of 0.59, which is truly quite remarkable. And at 1 year, there is almost a 20% improvement in survival between patients who receive nivo versus patients who receive docetaxel. Now, it's though worthwhile to understand the efficacy of this drug. It's worthwhile to look at the progression-free survival. So if you look at these curves, you can see in the beginning there's almost no difference between patients who receive nivo and patients who receive docetaxel. It's later on that the difference emerges. And at 1 year, there is almost a tripling of progression-free survival. And the reason why the progression-free survival is this way, in fact, if you look at the median, there's virtually no difference in the median, because a majority of the patients really don't benefit from nivo, actually also probably don't benefit from docetaxel. It's in the minority of patients that the drug benefits, but produces a very dramatic benefit that leads to the improvement in the overall progression-free survival and the improvement in survival. And this is suggested by the duration of response. This was at the time of data lock. So about 20% of the patients responded. But at the time of data analysis, over 60% of the patients had continued response. Whereas if you look at in patients who had chemotherapy, only 1 in 3 patients had continued response at the time of data analysis. So what this suggests is, yes, the drug may benefit in a minority of patients, but when the drug works, the duration of benefit is far longer than what we see with our currently available agents, and that's why the overall survival advantage observed. Now, the whole issue of PD-L1 testing, so in this study, PD-L1 was assessed, and in this study, though there was an improvement in outcome, both in overall survival and progression-free survival, in patients who had tumors that were PD-L1 positive, the test for interaction for this biomarker was negative in this study. That is, PD-L1 expression alone did not appear to predict for benefit in patients who received nivo as compared to patients who received docetaxel. We'll come to this issue again. So the other study that was presented at ASCO and then now published and has led to the approval of nivo, second approval of nivo in patients with non-squamous, was CheckMate 057, which showed a very similar improvement in survival, where the hazard ratio was 0.73. Important to note that the hazard ratio was 0.73, which is somewhat less than the hazard ratio of 0.59 in squamous cell patients, not because the benefit of nivo was any different between patients who got non-squamous and squamous. Actually, the patients who received docetaxel did better, probably because of the other agents that we can use in adenocarcinomas. And so the difference, what this suggests is that the benefit is the same in squamous versus non-squamous. Now, it's important to look at sort of the subset analysis that was presented, because it does jive with at least what is seen in the clinic, that in general, never smokers don't appear to derive as much benefit as patients who are current or former smokers. In my own practice, I really have not seen any of these drugs work in a never smoker, though if you look at some of the database, there does appear to be a response rate of about 8 to 10% in never smokers. Also, if you look at patients who are EGFR mutation positive, the trend actually was in favor of docetaxel in terms of overall survival compared to nivo. I don't want to give the sense that these drugs would not work at all in never smokers or patients with EGFR mutation, but clearly the efficacy seems to be less, and I'll come to this issue later. Now, when PD-L1 analysis was conducted in this study, PD-L1 did appear to predict for benefit as compared to docetaxel. So patients who received nivo, if they had PD-L1 positive tumors, definitely had better efficacy than patients who had PD-L1 positive tumors but received docetaxel. And again, I'll do my best to answer the discrepancy between these studies, that is CheckMate 017 and 57, with the same drug. The other drug that is now approved is pembrolizumab. This was based on a phase 1 trial, the Keynote 001 study. Important to note that there were 3 different sort of dose and schedules that were evaluated. The drug right now is approved at 200 milligrams every 3 weeks because they found in a large database of variety of tumors that there was not much of a difference between 2 milligram per kilogram or 10 milligram per kilogram every 3 weeks or every 2 weeks, and a flat dose of 200 was felt to be adequate in terms of efficacy across different databases. Now, what has been highlighted is the basis for the FDA approval. So the FDA approval was based on a response rate of 41% in about 61 patients in the validation cohort. So let me just very briefly mention what this means. There were a total of over 500 patients enrolled on Keynote 001. Both untreated and previously treated, though the untreated population was extremely small. They looked at 182 patients, which was their exploratory cohort, where they looked at whether PD-L1 expression predicted for benefit. And then the other 300-odd patients were a validation cohort. So this is 61 patients who had at least a PD-L1 expression of 50% or more. And in these 61 patients of the validation cohort, the response rate was 41%. 2 important points to note about this table or the response rate of pembrolizumab in this study. One is, if you look at the patients who are PD-L1 negative, yes, the response rate was lower, but a 9% response rate is not meaningless in a second-line setting or in patients with recurrent non-small cell lung cancer. That's what we see with docetaxel. The other important thing to note is that if you look at patients who were, treatment naive, though the numbers are much smaller, the response rate is the same. So we know with most cytotoxic agents, the response rate goes down in the second, third line setting. But with these drugs, and this is true about other drugs also, the efficacy is very similar, irrespective of what line of therapy you're using, as long as, if the drug is going to work, it's going to work whether you're using in the front line or second line. So in PD-L1 positive patients, the response rate of a single agent treatment, again, 17 patients, so one needs to be cautious about this, was almost 48%. These are the survival curves according to based on what the expression profile was. The red curve is the patients who had high tumor expression of PD-L1, with the median overall survival was 16 months. It was lower in patients with 1% or less of PD-L1 expression, but it's important to note that there remain a group of patients that appear to derive benefit from this drug, even though the response rate was lower. And the third drug on which we have some data, there are other drugs we have data on, is Atezolizumab. I like to say Atezolizumab because I don't think I'll be able to pronounce the whole drug. But this is a randomized phase 2 study, which randomized again in the second line setting to docetaxel versus Atezolizumab. These data were presented at ESMO just in October of this year. And in this rather randomized phase 2 study also, we saw an improvement in survival in patients who received Atezolizumab over docetaxel. Now, mind you, this is a randomized phase 2 study, Poplar. The randomized phase 3 study, OAK, has completed enrollment, and we are awaiting results. In this study also, they looked at PD-L1 expression, but they looked at PD-L1 expression not only in the tumor, but also in the immune cells. And what they found was that as long as you had expressed some level of expression of PD-L1, either in the tumor cells or immune cells, whether it was grade 1, 2, or 3, you had a benefit with Atezolizumab compared to docetaxel. But if you did not have any expression, either in the tumor cells or immune cells, there was no difference in survival between patients who received Atezolizumab or docetaxel. So what do we think about the PD-L1? And this is sort of a very quick summary as to how I view it. Clearly, the consistent data is if patient's tumor expresses PD-L1, the likelihood of benefit with these agents is higher. However, the results are inconsistent. Like we saw with Nivo, benefit was seen in 057 in the non-squamous population, but not in the squamous population. And part of the reason probably is because expression of PD-L1 is very heterogeneous. So if you biopsy a certain area of the tumor, within the same biopsy, you can see areas where there's high PD-L1 expression and areas where there's low PD-L1 expression. It can change with time, as was mentioned before, and in these studies, some of the tumors were archival, some of the tumors were fresh, and so some of the inconsistencies seen could be related to that. There was a difference in the antibodies used among the different studies. And for me, at the present time, the drugs have been approved in the recurrent setting. And in the recurrent setting, even in the pembrolizumab studies, what was seen is even if your tumor was PD-L1 negative, you could have a response rate of up to 8%. It's not the response rate of 8% that is relevant, but in the study what was shown was once you have a response, irrespective of whether your tumor was PD-L1 positive or not, the duration of response is the same. And so if you do happen to get a response, the benefit is the same, and therefore at the present time, at least in the second-line setting, I don't know if PD-L1 testing has a role. It could be used in select situations, such as in the frontline setting, or in never smokers, where the response rate is generally less to determine whether one needs to use. Markers such as mutational load probably have a greater relevance. So this is from a paper from the Memorial Sloan Kettering group that looked at pembrolizumab-treated non-small cell lung cancer patients and just assessed the number of mutations that were present in the tumor. And if tumors that had a high level of mutations appeared to have a benefit, as compared to patients whose tumors had low level of mutations, and whether these sort of genetic analysis, as was seen with ipilimumab in melanoma, will carry relevance or not remains to be seen. This was sort of one of the most exciting presentations at ASCO, where they showed almost an 85% response rate in MSI high colon cancer tumors, whereas if you look at overall colon cancer, it's only 5%. And the only reason it's different is in MSI high colon cancer, the mutational load is high. We are aware about the unique toxicities seen with these drugs. All the itis occur generally, though, at grade 1s and 2s with pembro, clearly higher with ipilimumab. Again, probably because ipilimumab leads to increasing circulating T cells, and therefore you see more autoimmune phenomena, whereas pembrolizumab or anti-PD-1 drugs, because they work in the tumor microenvironment, may not cause as much of autoimmune phenomena. An important thing to remember from the 017 study and 057 study is that toxicities actually were lower with Nivo compared to docetaxel, and most of the toxicities that were observed were grade 1 or 2 rather than grade 3 or 4. Even pneumonitis, which is a big concern in lung cancer patients, was not that common in patients who received nivolumab. There are several drugs that are currently in testing that are looking at anti-PD-1 or PD-L1 pathways, and we have some data on some of the other agents. And this is just a list of the drugs that are being evaluated. Of course, now we need to go to the next step. What is the next step is, can we combine this with other agents? And one clearly a combination that has been looked at already in melanoma is combination of anti-PD-1 and anti-CTLA-4. There's preclinical data to suggest that these combinations may be beneficial, because in preclinical models, when you inhibit one of the immune checkpoint inhibitors, there's increased expression of the other checkpoint inhibitor. And when you combine the two together, you don't see that increased expression. In addition, in the tumor microenvironment, you not only increase the number of activated cytotoxic C cells, but the combination appears to downregulate the immune suppressive cells. And so that has been the basis of evaluating this combination in melanoma, which I'm sure all of you know much better than I do, but the combination has shown greater efficacy. I'm involved with a phase 1 study with pembrolizumab that Dr. Langer is also participating in. And this is very early data of a combination of pembrolizumab and ipilimumab. Only 17 patients, but 71% of the patients had some level of tumor shrinkage with about 60% response rate. Whether this data holds up in a larger population of patients remains to be seen. Dr. Baumel discussed the small cell data, so I'm going to skip that. One thing I do want to mention is that though the response rate listed in the table was 17% with the combo of Nivo plus ipilimumab, this was at the time of the abstract submission. With further follow-up, the response rate with the combination was at 32.6%, suggesting that the combination may provide better benefit. One simple thing, which again, all of you may be very well aware from the melanoma data, that the combination is more toxic. And I wanted to finish up by talking about, so we have been focused on the anti-PD-L1, CTLA-4, or inhibitory molecules. As I mentioned, cytotoxic T cells do have co-stimulatory molecules, and there are several antibodies that are agonists of several of these molecules. I'm briefly going to talk about OX40 because we are about to start a study of this. Preclinical studies have shown it enhances the cytotoxic T cells. We have some very limited clinical data. This was a chimeric antibody that targeted OX40 in a phase 1 study where patients only received 1 dose of this agent. And even with just 1 dose, in some patients, there were a variety of tumors, including non-small cell lung cancer and melanoma. Some tumor shrinkage and tumor stability was observed. This was a sort of first-in-class agent. There are several other agents now in development. And this is a list of some of the agents, not only of the immune checkpoint inhibitors, but immune stimulatory molecules that are in development right now. And so we go back to the immune cycle because we definitely need to look at combinations. And as Dr. Haas mentioned, a better understanding of this immune cycle as to what molecules make most sense. And it may vary what combinations will be most effective in different patients based on the specificities of that patient's particular sort of tumor profile. In what combinations will be most effective. So in conclusion, clearly immune checkpoint inhibitors have now become an established treatment for non-small cell lung cancer, but benefits occurs only in a proportion of patients, and the reason there's excitement is that the benefits is sustained. The biomarkers still are undefined, unclear what the role of PD-L1 expression is in the recurrent setting, possibly in select settings such as frontline or in never smokers may be relevant. We've been looking at inhibitory molecules, but there's now interest in developing drugs that are activate stimulatory molecules, and we need to look at the combinations. Thank you very much.